inviting me here. I'm very excited to talk with everybody tonight about a topic that I'm very passionate about. And so I'm going to just share my slides and hopefully you can see those now. Are you seeing my title slide? Okay, awesome. Okay, so I'm going to go ahead and get started with tonight's topic, which is trauma among women in the carceral system, causes, consequences, interventions, and implementation strategies. And so before I dive in, we have a lot to go over, so I'm going to jump in quickly. I just wanted to review a couple small housekeeping items. In the lower left-hand side of the slides, you'll see slide numbers, and feel free to, if you have a question about something I'm talking about, just jot that number down. It'll help me find it later if you have a question related to a specific slide. Also in the upper right-hand side, you'll see references. Same thing, if you're interested in more information about a cited reference or that study, jot it down real quick, and I'm happy to connect with folks after the presentation for anything that you might be interested in. Danielle already did an awesome job of introducing me, so I won't belabor this. I'm just going to note I am in Arkansas, at the University of Arkansas for medical sciences, and a lot of the work that I'm going to cover is grounded in data coming out of Arkansas. I also have a professional role in the International Society for Traumatic Stress Studies, where I chair education production, and I just wanted to mention we have a virtual meeting starting next week, and I've always also wanted more representation from folks that are interested in the intersections of trauma and criminal justice, and I would invite y'all to join us there as well. So my program of research really focuses on what behavioral health interventions work in legal settings, such as prisons, and trying to answer questions related to that, as well as how do you get things done there, with an especially strong focus on how do you get things done there in recent years, because these settings are very under-resourced. They are responsible for the health care of a population that really has highly complex needs. And so this is a really important question. My work is supported by the National Institute on Drug Abuse, or NIDA, and I feel very lucky to have their support and for my time to be able to do presentations like this. NIDA has supported a number of the studies in a variety of ways that I will present tonight, as has the American Psychological Foundation. I'm going to just do a couple of quick acknowledgements up front because I think science is very much teamwork, and there are so many people that have contributed to the body of work that I'm going to present, including the members of my lab, and especially Dr. Katie Allison and Marley Bradley, my Career Development Award mentors who are listed there, and collaborators from the University of Arkansas, Dr. Anna Bridges and Dr. Marie Carlson. And I could not close that thanks out without saying thank you to the hundreds of women who have shared their experiences and inspire our team. So when preparing this talk, I thought it would not be appropriate to get a start without talking and acknowledging the current context, because the pandemic, of course, is affecting people in prisons and jails right now at extreme rates. And so it's worth acknowledging what is going on in these settings right now, including deaths of people that are incarcerated and staff that work at carceral prisons. Beyond deaths and severe illnesses, I think we're going to see a second wave of kind of consequences of the pandemic for folks that are incarcerated due to the effects of increased isolation. Many states have suspended visitation for reasons of infection control, further isolating people from support networks, family. And so I just think that we have to remember kind of the ongoing crisis and context when thinking about this topic at this particular moment in history. But diving into the meat of the presentation and what I'm going to focus on tonight, I'm going to focus on four main things. across the three aims that were in the presentation announcement. So I'll be summarizing literature on prevalence rates of trauma among incarcerated women, the role of trauma in women's incarceration, as well as talking about implementation strategies for integrating therapy for trauma sequelae in prisons, and discussing ongoing work that I'm doing to adapt evidence-based therapies for implementation in prisons. So that being said, that's our plan for tonight. If there are other things that you are hoping to get out of this presentation, just jot them down, put them in the chat box so that you don't lose them. And we'll see if I get to them within the course of these kind of major aims. You'll notice as I move through that at times I'll present national data and at times I'll present Arkansas data, and really this is meant to contextualize my work. And I'll at times present kind of the things we know for sure and lingering questions. I think just wanting to highlight what has been well answered at this point as related to this topic versus what are areas where a lot more inquiry is really needed. And if you're on the talk late on a Thursday evening, I suspect that you may already know about this, and it may not take much to convince you of the value of considering carceral settings as social determinants of health. But in case folks are unfamiliar, I just wanted to show some quick graphics. So the US is, of course, first in the world in terms of incarceration rates per capita, internationally exceptional rates of incarceration here. What I just highlighted in the red box is current 2012 through 2017 trends in incarceration rates state by state. You'll see Arkansas, where I am, has actually had the largest increase in state prison population during these years, in a time when many states are going the opposite direction and decreasing their rates. Women's incarceration has also changed over the past several decades. The number of incarcerated women grew during this time at twice the rate of men, over 750%. And Arkansas, again, where I am, has the 8th highest number of incarcerated women in the nation. And so I'm going to do a lot of talking at the individual and organizational levels tonight, but I think it's important to think about that there is an overarching policy level that's not well represented in my body of work that influences all of the things that I'm talking about, including the quite large increase in women's incarceration. And so I'm talking about the value of considering carceral settings, not with the goal of building better prisons or supporting carceral approaches to mental illness and addiction, but rather from the perspective that our nation really has a moral, legal, and ethical responsibility to provide quality health care, including mental health care, to people that are incarcerated today, even as we attempt to address mass incarceration. So I'm going to dive into the literature on prevalence rates of trauma among incarcerated women. And this literature is actually fairly straightforward, and the phenomena is very well documented at this point. So I've just selected a couple of papers that are some of the particularly strong ones, including this article by Holly Harner in 2015 that looked at women in maximum security prisons in the US and surveyed them on their trauma exposure as well as mental health. Basically what they found is consistent to what you would see across articles: high rates of trauma exposure across many, many different types of exposure. I thought it was really important to pull up why this article has stuck with me in particular out of many that have looked at women's trauma exposure is because of the table that they put in the article with examples of when women endorsed other traumas, what they meant. And you'll see all of these categories really focus on a whole lot of violence that women have experienced. So even if you just kind of scan the list here, you're seeing a whole lot of witnessing violence, long-term sexual victimization, and what they categorized as lifetime traumatic event, a lifetime of traumatic events, basically repeated chronic and severe trauma over many years. And if you look at articles that go further back and look at juveniles who are involved in the justice system and incarcerated, what you see are, even by teen years, there's a whole lot of exposure to violence, including witnessing violence, as you see in the top bar on the right-hand graph. All of this published work is very consistent with what we see here in Arkansas. This is from program development data. I'm a volunteer within our state's correctional system, as well as a researcher. And this was gathered some number of years ago in kind of planning implementation of program efforts. So domestic violence, as you can see in the pink bars here, is extraordinarily common among incarcerated women, 90% endorsing exposure. Sexual violence is also extraordinarily common, 70% compared to 10% of men who are incarcerated endorsed experiencing a lifetime sexual assault. And if we compare this to Arkansas rates of what is typical, it's about double if you compare to CDC data. So Arkansas sits around 38% of adults endorsing some lifetime sexual violence exposure, and incarcerated women are just about double that. This study kind of was a lit review where we drilled down into sexual violence exposure specifically and tried to determine prevalence rates. So this literature review was accepted a couple of years ago. It was put into print this year, actually. And this is just a quick glance of across studies that were large sample size, meaning at least 100 women. What we found was the vast majority of studies, again, found above this bar of what is expected at the population level that's represented by the red line on your screen, with studies with more rigorous methodologies represented in darker bars here. You can see that in the more rigorous studies, you see also rates that are about double. And that was for childhood sexual assault. And this graph shows the same comparison with lifetime sexual assault prevalence. And so what I feel like I can say I know for sure at this point is that nearly all women who become incarcerated have experienced trauma, and that it's often chronic and severe, and it often involved assaultive violence. So that is an area that for me, we don't need really additional studies, and we know that that's the case. If women are just as involved and incarcerated, they have experienced trauma, and often chronic and severe trauma. What's also possible or likely, and I'll show you data on this in a minute, is that sexual violence is a specific risk factor for women's incarceration, possibly due to cyclical relationship with PTSD and drug use. And so thinking over to the role of trauma in women's incarceration is it's been hypothesized for quite a while now that trauma, and particularly sexual victimization, is a pathway to prison. For women. So we see these higher rates of sexual trauma, we see these higher rates of substance use disorders and mental illnesses that are associated with sexual trauma. And, it makes you wonder about the connections. And so this is just kind of, again, going back to that review article that Dr. Carlson and I did, what is in that mental illness category of things that are exacerbated for incarcerated women. When looking at these figures that I'm showing you, you're going to compare the colored bars to the bars in black, which are community rates, whereas the color bars are studies that were done with incarcerated women and that use structured interviews to assess for mental illness. What you see across categories is that incarcerated women, the colored bars, have much higher rates of most mental illnesses, and especially depression, PTSD, and substance use disorders, with substance use disorders and alcohol use disorders exceeding over 10 times the rate of what is found in community samples. And I pulled this from an article, really foundational article in this area by Lynch and colleagues that was published in 2017, where they did a large study. It was almost 500 women, and did structured clinical interviews and used structural equation modeling to look at the associations between childhood trauma and adversity and number of convictions ultimately. And what they found, if you kind of just follow this figure through the center line, is that lifetime mental health and substance use disorders mediated that relationship between childhood trauma and adversity and number of convictions. And this is, consistent with patterns of what I'm seeing in a study that I'm doing right now that's following up with women an average of 3 to 5 years post-release. All of these participants have a sexual trauma history, and we're close to enrollment being closed in this study. So what we're seeing is very consistent in Arkansas, that very high rates of substance use disorder, depression, PTSD diagnoses. But what we're seeing in terms of when we ask people who have screened positive for one of these disorders within the past year, whether they have the treatment services that they need, we see this interesting pattern where people are endorsing having access or no longer needing treatment for substance use and alcohol use disorders. But for depression and PTSD, you see that the rate of people saying that they have the treatment that they need is much lower. So averaging around 60% for those with mental health concerns, and about 80 or over 80% for people with substance use disorders. And so there's a real need to figure out how do we get interventions for trauma-related sequelae to women who have been incarcerated at some point, because I bring all of this up, this study, to say that it sure looks like women are not getting access, at least in Arkansas, post-incarceration. And so why I have focused in on trauma and PTSD interventions in particular is really because of the relations between trauma, drug use, and incarceration. So we know from the data that PTSD development predicts the onset of drug use, and that PTSD symptom severity is linked to greater drug use severity. And then drug use is a risk factor for incarceration. So essentially something that's going to continue putting women at risk to cycle through the justice system. And in a study of prison-based substance use treatment, women with PTSD were more likely to relapse after release than same-sex peers without PTSD. So with regard to the question of essentially how does trauma exposure link with justice involvement, we know that incarcerated women have these higher rates of mental illnesses, especially trauma-related disorders and substance use disorders. And it seems like assaultive violence may play a unique role. And together, these factors are going to put women at risk for repeated incarceration. So really the lingering question is then, well, what do we do about that, right? We've got lots and lots of data going back many years at this point to support this. What are we going to do? And this question is an especially interesting one in light of arguments that have made against providing trauma therapy in prisons, really coming from this place of wanting to not risk, bringing up really challenging topics in a time where women are in a system that's marked with power and control. So this is a quote from one article that laid out a rationale that I've seen commonly across papers that take this position. The authors wrote that the most robust evidence base supports exposure therapy, a past-focused intervention that explores emotions and thought processes related to traumatic experiences. This intervention is categorized as a second stage intervention, which must be delivered in a safe and supportive environment. Authoritative settings, authoritative and punitive settings like prisons do not meet standards for exposure processing. And so the hard thing about this is if we roll with this rationale, it really puts us in a bind, because what we're seeing is that the trauma-related sequelae, the PTSD, the substance use puts women at risk for cycling through the justice system. In the follow-up study that I'm doing, it's looking like women, we have some detailed questions about what kinds of treatments women that are in treatment even have had access to, and it's not looking like they really have access, at least in our state, to evidence-based therapies for PTSD. And if you look to the research on what's been done in terms of interventions that have been tested in carceral settings in more rigorous ways, like with RCTs, a lot of the interventions that have been tested have been more coping focused interventions that are not likely to maximize recovery. And so I just wanted to bring that back up to say, we have to think about a cost benefit here, and really the question of, is this something that's likely to happen? Are women likely to get treatment if we defer and don't offer them in carceral settings? And so I'm just bringing up one more graphic from this study that, again, is in progress. We asked women 3 to 5 years post-release whether they had certain types of providers, and only 13% had a psychiatrist and 11% of women in the community had a therapist. And we actually interviewed and surveyed a number of women who were reincarcerated for this study post that original release. And you can see on the has a therapist bar in green that actually a higher percentage of women that were incarcerated endorsed having a therapist than women in the community. So really, again, highlighting how limited post-release service access is. And so this is what's driven me to move from the question of should we do trauma-focused interventions within prisons to more the question of how do we do it, recognizing that there are very real differences between doing therapeutic interventions in prisons versus in the community. And so I'm going to describe 2 studies, one that's complete and another one that's ongoing work right now, that have sat at the intersection of implementation science and these topics. And for folks that are not familiar with implementation science, I just pulled a quote from the great Enola Proctor, who wrote, one of the most critical issues in mental health services research is the gap between what is known about effective treatment and what is provided to consumers in routine care. So if you swap out consumers in routine care and swap in women in prisons, I think you'll get the point that I'm trying to make here, which is that we know what good treatments options are for many of the problems that incarcerated women are struggling with: PTSD, depression, substance use disorders. But we also know that there's a gap between what we know and what's actually provided in care. And the implementation science research that really looks at more of the what strategies you use, how do you get this done, has been primarily limited to it within carceral settings to studies that have looked at implementation related outcomes like REACH. And then there has been lots of work on perceived or actual barriers or facilitators to interventions. But there's been less research on more of what are the strategies, what are the things that folks looking to bring evidence-based interventions to these settings can do to effectively support implementation within prisons in particular. NIDA has funded several notable exceptions, and if folks are interested in this area of work, I just wanted to put up a couple of plugs for the line of research that has been done in these settings, which NIDA has really been championing, including with the ongoing HEAL and JCoin initiatives. But the study I'm going to focus on related to this topic, it just came out in the American Journal of Community Psychology, and its special issue actually on the relation between community psychology and work in justice settings, titled Implementing and Sustaining SHARE, which SHARE is an exposure-based psychotherapy group for incarcerated women who are survivors of sexual violence. And this is a project that I've been involved in a long time back as a clinician running SHARE groups in this facility. And then with this study, it was really a retrospective look back at essentially how did we get this intervention into place, and how have we kept it going? So the short version, like I said, of SHARE is that it's an exposure-based group therapy. It has been running at a particular correction center in Northwest Arkansas since January of 2012 through present. In this time, the team has run over 40 groups and had over 250 treatment completers. We've done several open label pilots of effectiveness. And as I moved into implementation science and this question of how do we bring these treatments to justice settings, I realized there was a real opportunity to naturalistically study implementation and really the long-term influences on sustainability. Oftentimes trial or studies that look at sustainability of interventions, the sustainability period typically ends when like grant funding ends, or when like a planned a period to look at sustainability ends. And here we have this naturalistic example of, at the time of the work, 8 years of SHARE being in place in the facility. If you're interested in the actual intervention, because I'm not going to talk about it much more than that, we have several articles that have been published, and I can pull up this slide later so that folks can see the citations. But what I did for this particular study, it was a retrospective look back of what we call a process evaluation of implementation, where essentially I interviewed a bunch of people and asked them about their recollections of the steps that were taken to get SHARE in place and keep it going. And so today I'm going to focus on a subset of those that were involved in implementation, people that I interviewed that were on the SHARE intervention team, as well as staff at the correction center. I did also interview women that participated in the program, didn't participate in the program, and didn't intend to ever, as well as women that didn't participate and were interested in doing so. And results of that are in the manuscript if you're interested. But for the implementation piece, I essentially interviewed folks using a framework called EPIS, which is the Exploration, Preparation, Implementation, and Sustainment framework. And this is an implementation science framework that really is well suited for work that is trying to describe the process of moving an intervention into practice over time. And so there are 4 phases. In an exploration phase, essentially stakeholders are starting to think about doing something for the target population. So in this case, justice involved incarcerated women, and they're working to identify an intervention that can match their needs. So in this case, the need for women to have access to treatment for sexual violence, sequelae. In the preparation phase, basically that's the period after the intervention is selected. So SHARE is selected, and at that point, stakeholders are more doing the heavy lifting of getting ready to start offering that intervention. Then the implementation phase is going to start when at the initiation of the program. So when SHARE was first put into place, and then finally in sustainment, that's after the majority of the program is in place, running, and continues going over time. And so the idea is that across these 4 phases, there are 4 factors that are really going to have a heavy role in implementation of the program. And those are represented in the middle of the figure. You can see the outer context, the inner context, and then in the middle, bridging factors and innovation factors. And I'll talk a little bit more about that within the context of the specific study. So what I was expecting to see when I started this work was that basically we had this treatment team, the SHARE treatment team on the left-hand side of the slide, that was comprised of people from a university as well as a domestic violence shelter that were essentially going into the correction center and offering this intervention. And the people that are represented here are the people that I interviewed. I expected that the correction center itself would be essentially the inner setting because it's where we were delivering the intervention. And that according to the EPIS model, the outer setting would be the broader sociopolitical context, policy, environment that the prison was in. what actually emerged from the data was much, much more complicated. And there were overlaps between inner and outer contexts at every single one of the agencies involved in implementation. And so this picture, really the only thing that I changed that was meant to represent the actual implementation process was that what we found was that folks involved in implementation had were really spanning multiple contexts, and that's probably a large part of what made it work. So you'll see the little people are now multicolored in many instances, and I'll just give you some examples of what this is representing. So on the very left hand side, there are two figures that are red on the top and pink on the bottom. This is two of the people that were involved in the exploration preparation, really getting Share up and started, were both affiliated with the university and had a primary affiliation with the university, but were also affiliated with the shelter. One of them, in addition to being a university student, was a practical student at the shelter. And then the other was a clinical supervisor and also a member of the board of directors at the shelter. And then the sole figure on the right-hand side underneath the shelter bubble is pink and blue. And she was a social worker at the shelter, primary affiliation with the shelter, but had been onboarded quite a few years prior to Share implementation as a volunteer in the prison. And so those are just a couple of examples of how it got really complicated really quickly to kind of look at you know, the varying ways in which people were nested and what factors might have resulted in this really, really successful implementation effort of 8 years of something being in place, honestly, on very little funding. And it highlights the importance of what is called bridging factors in EPIS. So people, partnerships that span multiple settings. So in this case, I would say all of those people that I just talked about, the people that I didn't talk about that were multicolored, really were bridging factors, linking multiple inner contexts, the university, the domestic violence shelter, and the prison together with the mutual goal of getting this intervention into place. We also found really important organizational shifts over time that supported implementation, which at the start, it was that the university and the shelter were linked together, and the prison and the shelter were linked together. And both of those places had partnerships with the shelter, but the university and the prison were not working on anything together, really didn't have any active connection. But over time, what we saw was that Share provided an occasion for all three of these settings to link. And after a little bit of time, actually the shelter split off. The university and the prison had formed a relationship, were actively working together in context of these implementation efforts. The social worker I mentioned on one of the previous slides actually left. But at that point, the shelter's work as kind of a linking agency had already been done. And so if you look forward 8 years, really what's been in place the whole time is that now after that kind of organizational warm handoff, I could almost call it, there has been a relationship between just the university and the prison kind of keeping this going. And so when we think about why Share was in place and things that folks might want to think about in thinking about these correctional academic partnerships, which I think are really promising potential implementation strategies, was that there was a whole lot of compatibility between the needs and resources of each organization that was involved. And in many cases, it was that one setting had what another setting didn't have, but was mutually complementary. And then there were some factors that were really shared between all. So for example, you know, people in all three of these organizations realized how important it was for incarcerated women to get therapy for sexual violence victimization sequelae, and they had compatible availability. And this was something that was just critical throughout all of the phases of implementation. There are some things that really differed. So for example, this particular prison was rehabilitation focused. They had many women that needed therapy for sexual violence victimization, but it was also likely an important factor that they really didn't have the ability to internally facilitate interventions themselves. And they were reliant on volunteers for this. And at the same time, the university setting had a supervisor and doctoral psychology students who really wanted experiences treating trauma, wanted experiences in community placements, and who were willing and able to provide those services at no cost. And you see the same kind of pattern in terms of outer setting or more socio-political kinds of factors, that there were some that all shared, and then there were some factors that were specific to just certain settings. And so in thinking about how do we get interventions into carceral settings for trauma, I think we can think about it through the lens of, so why was SHARE sustained? Essentially what we found was that each organization was bringing to the table things that other organizations didn't have. And this explained why SHARE didn't cease to exist when the shelter was no longer involved. So one potential strategy is academic partnerships like this, where external providers are actually the ones facilitating treatment groups. Most carceral facilities have volunteer programs through which this kind of strategy could work and could take care of the concern that internal providers within a punitive setting might not be the best ones to provide these kinds of therapies. In terms of implementation strategies, I'm just going to skip those couple of slides looking at time. I wanted to highlight that there were many different strategies that were leveraged to get SHARE into place and to keep it into place. There was a lot of assessment for readiness, identifying facilitators and barriers, modifying the strategies to get this into place. There were educational meetings, there were ongoing communication channels formed. And so what we found in this implementation kind of retrospective look back was no less than 15 strategies that were used to get SHARE into place. And here's just one quote. This was qualitative data, although I don't have time to go over it at that level, of something that was related to tailoring. So one stakeholder on the SHARE treatment team mentioned that they started giving certificates of completion. It wasn't something they planned on the front end, but turned out to be super important. And why that was so important is that women who are incarcerated in these settings often they need to show that they're doing different things while they're incarcerated, and completing programs is something that's really meaningful and valuable internally. And also we saw in our data, actually for women's own mastery, we saw that come up several times where participants just talked about really feeling like they had accomplished something when they were able to get a certificate to say that they worked on these issues. Okay, and then I'm going to move into talking about a study that's more focused on adaptation, because it's a prospective evaluation I'm doing right now, a process evaluation I've just wrapped up that is going to inform adaptation of cognitive processing therapy for implementation in prisons. And I imagine many folks may be familiar, but in case not, CPT is a gold standard evidence-based therapy for PTSD. And there's good reason to believe that non-specialists can deliver it effectively. That was a big reason and why I chose it for this project, was that data showing in actually international contexts and conflict zones, Deborah Kaysen's work, that even folks with high school degrees could deliver the CPT skills. And so what my K is working towards, my Career Development Award is working towards, is training internal providers to deliver an adapted version of CPT that's been modified to fit the setting. And so doing the formative evaluation, what I'm really working to try to do is to identify anticipated implementation influences, meaning barriers or things that would get in the way, and facilitators or things that would help with implementation on the front end, so that we can come up with an implementation plan that minimizes the effect of anything that would potentially get in the way and take advantage of facilitators. I've got 2 project sites on this project. Both of them are, again, community correction centers in Arkansas, which are kind of interesting facilities. They're both carceral lockdown facilities, but they're also licensed drug and alcohol treatment centers that provide a significant amount of substance use treatment per week already. And the process on this project, again, maybe I'm kidding myself, but it seems like the expected implementation process will be more straightforward, because in this case, the project team is really training internal providers to offer this. And so we conducted the interviews through that lens. The figures up here represent the people that we interviewed. I basically interviewed anyone that the site says was important for me to talk to in thinking about how to implement this therapy. This included staff as well as residents incarcerated in the facility. And I used a slightly different implementation framework, but you can see that many of, or several of the terms up here are the same. This is the consolidated framework for implementation research. And it also thinks about the critical role of inner and outer setting factors in implementation, as well as factors related to the people that are involved in intervention delivery and the characteristics of the intervention itself. And so I did a bunch of qualitative interviews, like I mentioned. Here are just some example questions of what was asked in each domain. I did a really extensive familiarization with CPT, physically showing people the therapy materials, going over a detailed rationale and kind of boiled down version of the intervention before asking these questions, and then talk to people basically about how things like, how does CPT compare to existing programs that they were offering? What kind of changes did they think that CPT would need to work in that setting? In the inner setting, asking questions about essentially how the structure of the prison might affect implementation, how the prison's culture might affect implementation, so on and so forth. And so this data has now been qualitatively analyzed, and the results are represented here in this big table that is a little bit too complex to see all in one place. So I'm going to break it down into parts. And just highlight a couple of examples of how studies like this can help us think about how to adapt interventions like trauma-focused treatments for implementation in carceral settings. So inner setting, meaning things kind of related to the prisons in which this adapted treatment will be implemented. We found barriers like that are more to do with scheduling, so that CPT might have a lower relative priority than some of the mandatory classes, because this is something that we need to stay voluntary. We found barriers around available resources, staffing issues, a high programming burden already for residents and staff, possibly related to culture. Some of the same themes as has been highlighted in past research, like power and control dynamics, and that oftentimes not sharing much is adaptive. We also did find a number of facilitators, and compatibility was really the biggest one. It's actually kind of blown me away how compatible CPT seems to be with the work being done in these facilities already, which is highly cognitive behaviorally based, even if taking more of a criminogenic lens. So we saw really strong compatibility with the facility population and their needs around trauma recovery, a lot of openness and excitement about an intervention like CPT being in place. We also saw that the practical resources exist. There are classrooms already. The structure of the prison is one that would support implementation. And these facilities are actually kind of used to pilots, and that's something we would imagine helping kind of with initial implementation. And so as you think about each of these influences, I'm just going to kind of pull up some quotes that highlight some of the barriers and some of the facilitators. So you can kind of see what this looks like in a really practical sense. And then what we do from a strategy standpoint is we think about, okay, now knowing these barriers and facilitators, what kinds of strategies might be useful in overcoming the barriers and taking advantage of the facilitators. And these are actually going to be decided through a process where we engage stakeholders in making choices. I've just pulled some for demonstration purposes from the Eric strategies, which is a compilation of 72 that were enumerated a number of years ago. So for example, with the intersetting barriers and facilitators I described, some strategies that might help overcome those would be having a team that's experienced develop a formal implementation blueprint of like, okay, so we're up against these barriers, staffing's a problem. Let's think about how we can get this done and really map out every step of the process. Another thing that could be done to overcome those barriers are doing things like mandate change, revising professional roles, making it a particular person's responsibility to implement CPT. And I'm going to kind of skip over to the adaptation strategy. So what we saw, CFER actually puts the needs and resources of the population being served in the outer setting rather than the inner setting. The population being served in this case being the people that are incarcerated. And one thing that we saw was that was likely to be a barrier was literacy. This came up a lot in the interviews, both with staff and with residents, talking about literacy is a challenge, being able to read is a challenge, and just self-consciousness even about reading and spelling as something that might prohibit people from taking part in the intervention. And so a strategy that although stakeholders will be engaging in a process of picking the implementation strategies, one thing I've just been able to kind of run with in the background is this promote adaptability and working on tailoring. CPT has been intended all along to better match the population. And so I had two stakeholders talk about, like we brainstormed a little bit in the context of these interviews about, okay, so like how could we change things to best fit the populations? And two people had suggested the idea of somehow using shapes. And so I've been working, like I said, in the background to adapt some of the materials to be more picture-based and to use shapes to illustrate concepts. So here's an example like ABC sheet that I've taken and used icons and shapes to show events, thoughts, and feelings, and just basically kind of simplify things. So in wanting to leave a time for questions, I'm going to kind of jump to the end on this. Essentially what we know for sure is at this point is that trauma treatments in carceral settings are possible and they're actually well received. I have a lot of data that can speak to the well received, but maybe just will highlight the one point of, SHARE as a program as an example that's been in place for 8 years on almost no funding and has continuously enrolled women in even an exposure-based intervention that involves talking about sexual violence. And I also am noticing that academic correctional partnerships, like the one that we kind of stumbled into with SHARE, may be really a particularly useful staffing strategy. I think lingering questions are, what degree of adaptation is necessary? Can we do minor tweaks, like tweaks to materials, like I've been working on? Do we need to do more major changes to meet, for example, licensing restrictions? So I think there are some open questions around that, as well as questions around who should be providing the interventions and how might women that are incarcerated kind of respond to internal providers versus external providers, and what are strategies that can support internal providers should that be the staffing strategy selected. And so, a couple of years down the line coming out of my K, I'll have more information on that, but I think it's still definitely an open question at this time. So that'll bring me to the end of my slides. Thank you very much. I've been very excited to be here with you all tonight, and I'm very happy to connect on this topic after.
Thank you so much, Melissa. It was a great presentation. We've got some good questions here.
Yeah.
So the first, someone asked if they wanted to know if the groups continue after the individuals are discharged from the facility, and related to that, how do they continue the work when they get out, or are there specific discharge recommendations that they take with them?
Mm-hmm. The short answer really is no at this point. SHARE, for example, was constructed to be short, kind of with a population health frame in mind of, what is the dose of the intervention that would help us both make an impact at the individual level and move multiple people through the intervention in a way that would maximize the effect on population health. And so it's very brief, and there is no follow-up directly from that program. The facility that it's offered in does do some level of discharge planning, but I presented, and I don't know, on how representative the sample that I've recruited for the follow-up study is yet at this point. We'll do those comparisons before we publish, but among the women that I could talk to 3 to 5 years down the line, most of them, like I showed in those data points, do not appear to have active connection to specialty mental health.
Okay. And related to kind of the representation of the makeup of the sample, do you have any data regarding the demographics of the population from the different facilities that you've run the group in?
Yes. I don't have it on a slide that I can pull up. I can tell you though, it's very consistent across. So all of these facilities are heavily white, actually, in excess sometimes of 90% non-Latino white. That data does come from our Department of Corrections, which I know the number of categories they collect is limited. But in the CPT adaptation study, I actually went back to oversample women that were non-white and talked to 3 out of the 8 that were in the facility at that moment. And so it really is a limitation at this point in terms of racial ethnic diversity. I think other types of demographic characteristics really have been also consistent across studies. Women are very commonly moms to multiple children, very commonly low SES. Average education, I think, sits below high school. That's generally what we see. Average age is usually between like 32 and 34 in these facilities.
Thank you. Okay, so this one says, it seems that the literature is not as well developed regarding post-release trauma, especially trauma or PTSD that results from incarceration, or about how prison itself can be re-traumatizing. I was wondering if you had any thoughts about this, and also, do you think using these adapted treatments might help to reduce or prevent the traumatization of prison and the justice system?
I think that's a really interesting question and a really good point. It's one that I think about a lot, and I've scoured the literature. So if anyone's read studies that have actually been able to look at kind of pre-post effects of incarceration on PTSD symptoms, for example, I'd be very excited to hear about that. I haven't seen anything. So I agree, it seems like that's more underdeveloped. I can show one slide that addresses part of that point really briefly that I didn't show before. So this slide is again from the study we're doing that's following up with women 3 to 5 years down the line. And we asked about violence victimization in relation to incarceration. And purple means before incarceration only, green means both before and after, and then blue is after only. And something I find really interesting about this graph is this last category here. So we're seeing domestic and intimate partner violence. Actually, a chunk of women that are saying that they experience this after incarceration only. This could align with developmental timing of the initiation of intimate partner relationships, but it also is making me wonder, people lose a lot, right, when they become incarcerated, and in terms of housing, financial resources, things that you might expect might make people reliant on intimate partners and have maybe put them at risk for IPV. So I think that's a question that seeing this data so far has made me wonder, kind of to your point.
Mm-hmm.
I feel like I missed part of that question. Did I miss part of that question? Or did I get all the parts?
I think so. Yeah,
Okay.
I think yes, you did. Next, we just have a couple more questions. So, in addition to mental health and trauma focused needs, research generally shows that women have similar criminogenic risk factors as men. And someone wondered, how can we better balance trauma-informed care with interventions focused more on those traditional recidivism reduction factors like criminal thinking, engaging with antisocial peers? Any thoughts about that?
Yeah, a lot actually. Like this, I mentioned the term compatibility earlier, from the implementation science kind of frame. I think there's so much compatibility there already in terms of like the emphasis on cognitive processes that honestly, like it doesn't take much tweaking. Like the skills are very similar that you're teaching people. And so if you can kind of think about that, maybe we could um, kill two birds with one stone in a lot of ways by going the trauma route and then integrating work on thought processes that intersect with some of the more criminogenic ways of thinking about thought processes that need to be changed to reduce recidivism. I really see just so much overlap there. So yeah.
Yeah, thank you. Okay, is there a pre-test or a post-test to the groups, and how is the success measured?
Mm-hmm. Yeah, so there are several articles out on Share at this point, and so that we have done several open label pilots with pre and post depression, PTSD, and anxiety symptoms in particular. Um, it's an open label pilot. There's no comparison group, and the pre-post results look promising. We get large effect sizes on the measures that we look at with that. And improvements further in PTSD at follow-up while people are still incarcerated. The study that I've been talking about that's in progress will look at longer term changes in mental health symptoms, though the sample size is going to be small.
Mm-hmm, mm-hmm. Well, and it seems like people were really, really interested in information that was contained within the slides, the statistics about trauma in general in carceral settings, and looking at state by time analyses. So with that, would you be willing to share some of those slides? And related to that, people were also wondering if those SHAPE worksheets that you adapted were available.
Yes, I'm happy to share resources. I have not posted anything anywhere on the SHAPE worksheets, but I will. I actually, am open to getting with folks about those as well.
Awesome. Yeah, and we can connect and get those resources from you. Well, I think that wraps up the question section. So again, just on behalf of Division 18, thank you so much for this webinar. It was really informative, and we appreciate it.
Thank you very much for having me.
Dr. Zielinski, thank you so much. It was a great presentation.
Yes, no, you're very welcome. Very happy to have been here and gotten this.
Yes.
All right.
And everyone that's left, please fill out the survey, even if you're not getting credits, because we really want to get your feedback on the presentation, as well as what topics you might want to hear in the future. I hope everyone has a good night, and I hope to see everyone at our next webinar. Thanks, everyone. Bye-bye.